Good morning to everyone, and thank you for joining us on this Saturday morning for the first of our Women in Epilepsy webinar series. We are presenting this morning on living well with epilepsy and women's health with the fantastic Dr. Nancy Hammond from the University of Kansas Medical Center. And I, without further ado, will turn it over to you, Dr. Hammond.
Great, thank you, Laura. So as Laura said, I am an epileptologist at the University of Kansas in Kansas City, and my passion in treating epilepsy patients is helping manage women throughout all of the changes that come during their lifetime. Now, some of these changes occur before I happen to take care of them because I only take care of adult patients, but today I'm hoping to talk through puberty, things that happen with menstruation, contraception, and then we'll spend a lot of time on managing epilepsy throughout pregnancy. So prior to puberty, epilepsy is basically the same for both boys and girls. The changes that occur when a girl goes through puberty can present special challenges when trying to manage epilepsy. Puberty is when girls with epilepsy may first experience something called catamenial epilepsy, or epilepsy that's related to their menstrual cycles. Puberty is also a time when some seizures tend to get better, such as absence epilepsy, and other types of epilepsy can actually start to occur around puberty, such as juvenile myoclonic epilepsy. In addition, as girls are growing, growth and development may affect anti-seizure medication levels, which can lead to breakthrough seizures. So if your daughter or you are going through puberty and you notice that your seizures seem to be getting worse, it might be worthwhile to check your levels just to see if changes in your body size have dropped your medicine levels. Sometimes women and girls with epilepsy will have irregular periods, meaning that they don't occur at regular intervals, but most of the time, women and girls with epilepsy have regular cycles once they sort of level out. It takes about 2 years from when a girl first starts having her period until her cycles become somewhat regular. Some girls are a little bit faster than that, some girls are a little bit slower than that, and if you have concerns, I would encourage you to talk to your doctor. So this is probably the most medically related slide that I'm going to show you today, and I don't want to spend a whole lot of time on it, but I did want to point out this is a menstrual cycle. So this is what happens in a woman's body when an egg, that's shown up here, matures, and it's released from the ovary in a process called ovulation. After the egg is released, it travels through the fallopian tubes into the uterus. And then if there is no fertilization, meaning that the woman doesn't get pregnant, then the uterine lining, which is shown down here, will start to decline, and that's what gives her period. The main reason I wanted to show this slide was because I wanted to point out two very important hormones that change during the menstrual cycle. So the first one is this blue line right here. This is estrogen. So if you follow this blue line, you see right before ovulation occurs, there's a big spike in estrogen. And then estrogen sort of declines. But right here before the menstrual period starts, there is a little bit of a time where there's more estrogen than progesterone. And that's important because anytime you have a spike in estrogen or more estrogen than progesterone, that's a time when you might be susceptible to seizures. Progesterone, which is this black line here, as you see, it kind of stays level until ovulation and then starts to come up and then decline as the cycle progresses, assuming there's no pregnancy. If the woman does get pregnant, this progesterone actually continues to go up, and progesterone is one of the main pregnancy hormones. Progesterone is felt to be protective against seizures. So the times when women are more likely to have seizures during their menstrual cycle are this time right before ovulation and then also right before her period starts. So that's called catamenial epilepsy, which is just a change in the seizure frequency, usually related to the menstrual cycles. And it can kind of occur at 3 different times, but the most common type of catamenial epilepsy is the type that occurs either right before or right after her period starts, and that's called perimenstrual. The next most common type is when you see that, when I showed you that spike of estrogen right before ovulation. So that's another time when a woman might have more seizures. And then in some women, that ovulation doesn't occur correctly. And we'll actually talk about that a little bit on the next slide. And so the progesterone spike that you usually see in that second part of the menstrual cycle doesn't occur. So some women may notice between basically the last 2 weeks of their cycle that they may have an increase in seizures. Unfortunately, even though this is a well-recognized condition that occurs in women with epilepsy, there's not a whole lot of treatments for catamenial epilepsy. Some people will use progesterone pills to sort of supplement a woman's natural progesterone. And that particularly seems to work well for these women that have this sort of perimenstrual seizures, or seizures that occur right around menstruation. There's also some other seizure medicines. Some of you might be on them already, such as clobazam. Sometimes we'll give extra doses of clobazam around the menstrual cycle. Or sometimes we might even just give you a little bit extra of your medicine that you're on regularly to sort of protect you against those seizures during those times. This really only works to kind of doing this cyclical dosing of medicines if your periods are regular. A lot of my patients have menstrual cycles that are sort of unpredictable. And so those seizures are a lot harder to manage, just because I can't say, okay, well, in 28 days, you need to start taking this. Because they may have a seizure, they may have a period in 2 weeks, they may have a period in 6 weeks, and sometimes they just don't know. So the best thing would be to work with both your neurologist and your gynecologist to, one, see if you can get your menstrual cycles a little bit more regular, and to see if there's a reason why your menstrual cycles are irregular. And then two, to also figure out what we might be able to do to help soften the blow of those catamenial seizures. So polycystic ovarian syndrome is a relatively common disease. It affects maybe around 10% of women. That's just women in general, not particularly women with epilepsy. But polycystic ovarian syndrome is found a little bit more common in women with epilepsy, and we don't exactly know why. So polycystic ovarian syndrome is a condition where the woman's egg is not released from the ovary. These eggs will then sit in the ovary and form cysts, which cause abnormal hormone levels, particularly an increase in testosterone, which is more of a male hormone. And that leads to a hair growth in places that women don't necessarily want it, such as on her face. It can also lead to irregular periods, weight gain, and a whole host of other symptoms that I don't really want to go into. We have found that polycystic ovarian syndrome is more common in women with epilepsy and may be related to use of specific medications, particularly sodium valproate, which you might also know as Depakote. Interestingly, polycystic ovarian syndrome may also be more common in women with left temporal lobe epilepsy. And we don't really understand why that is at all, although there's certain thought that the left temporal lobe affects some of the hormones in the woman's hypothalamus, which is a part of the brain that sort of controls her menstrual cycles. And then polycystic ovarian syndrome may also worsen seizures in women with epilepsy. And so if you have any symptoms of polycystic ovarian syndrome, particularly irregular periods, hair growth where you don't necessarily want it, and weight gain, it may be worth talking with your physician about whether or not you have polycystic ovarian syndrome. I'm going to touch briefly on contraception. And so sort of the good news is that there's lots of methods of contraception for women with epilepsy. Women with epilepsy can and do get pregnant. It's estimated that about 50% or half of the pregnancies that occur in women with epilepsy are not necessarily planned. So I always tell my patients, if they're sexually active and they do not want to get pregnant, they should use some form of contraception. And then you should also be aware that particularly if you're using oral contraceptive pills, there's lots of seizure medicines that interact with the oral contraceptive pills and may make them less effective. So the pill might not be your best option. Your gynecologist or your neurologist should be able to discuss with you if you're on one of those medicines and talk to you about the different options. There's IUDs, which is what's pictured here. There's also a depot shot, which I found to be fairly helpful in my women with epilepsy. The only problem with that is that it can affect your bone health, which is a problem as women age in general, but it can also be worse in women with epilepsy, that their bone health is not as good, which might lead them to fractures. So once again, it's best to just talk with your doctor about what the right option is for you. So I'm going to move now into pregnancy. And the reason that I spend a lot of time on pregnancy is because epilepsy affects both the woman who is pregnant and can potentially affect her baby. And it's also an area where there's been a fair amount of research. And so we have some good concrete suggestions for managing your epilepsy while you're pregnant. So thinking about becoming pregnant when you're living with a chronic disease like epilepsy can be very stressful. So hopefully today we'll be able to ease some of that stress and assure you that women with epilepsy can successfully manage to become a mother and have a healthy pregnancy. It usually takes a little bit more planning, and you are probably going to be seeing your doctor a little bit more, but you can have a great outcome. And most of my patients do, in fact, go on to have very healthy pregnancies and healthy babies. And that's the goal. So some of the questions that women ask me when they're trying to get pregnant or thinking about getting pregnant is, number one, can I get pregnant? What will happen to my seizures when I get pregnant? And they want to know if their medicines are going to affect their baby, or if their seizures are going to get worse, or how their pregnancy is going to be different than that of their friends or their sisters. They also want to know, what do I do if I have a seizure when I'm pregnant? And then as the baby, pregnancy progresses, they want to know, how's this baby coming out? And can I breastfeed? And what else do I have to think about when I'm home alone with the baby, when I'm living with epilepsy and have a baby at home? In an ideal world, every woman with epilepsy would have at least one prenatal counseling visit with their physician, hopefully with their neurologist that's treating their epilepsy. I actually run a special clinic for pregnant women at the University of Kansas. And so if that's something you're interested in, you can contact us and we will get you in my pregnancy clinic. So I see women who are both thinking about becoming pregnant and then also women that are currently pregnant. So the goals when I see somebody for a prenatal counseling visit is to optimize your treatment of your epilepsy and make sure that you're on the right medicines, make sure that you're on good doses of medicines, talk about seizure control, make sure that in fact you do still need to take your medicines, because sometimes maybe if you had a few seizures when you were a child, you might not actually need medicines anymore. And then the most important thing that I do when a woman is contemplating pregnancy is make sure that she's taking folic acid. So it's recommended that any woman in the United States who could potentially become pregnant, epilepsy or not, takes folic acid. You can find this in multivitamins, or you can buy it on your own at the drugstore. So the first question is, can you get pregnant if you have epilepsy? Absolutely. Yes, you can. And so there was a study that was done where they followed women with epilepsy and compared them to women without epilepsy. And so these were often friends or siblings of the women with epilepsy. And what they found was that there was no difference in the percentage of women who were able to get pregnant, and it didn't take them any longer time or shorter time to get pregnant. So there's absolutely no difference in fertility in women with epilepsy. So that's good news. And I certainly have patients who struggle with infertility. I think infertility is a fairly common disease that nobody talks about. And I try to do the best to make sure that their epilepsy is well controlled as they're going through fertility treatments. And there's also no evidence that fertility treatments worsen epilepsy. So if you are a woman that wants to get pregnant and you're having struggles with infertility, your epilepsy should not hold you back from going through those fertility treatments if needed. What happens to your seizures? So most of the time, seizures stay the same. So if you were seizure-free before pregnancy, the chances are high that you're going to maintain seizure freedom during your pregnancy. So that's good news. Most of the time, the seizures don't change. And then I spend a lot of time talking about birth defects because that's the thing that we worry about the most for the baby of the woman with epilepsy. The risk of birth defects is higher in women with epilepsy who take seizure medicines. Certain medicines do have an increased risk, and using more than one medicine also increase your risks. But on the flip side, there are also risks to having seizures during pregnancy, and I'll talk a little bit about those in a minute. The good news is that by far and away, most women with epilepsy have healthy babies and healthy pregnancies. So when I see a woman, before she gets pregnant, we try to change her from polytherapy, which is taking more than one medicine, to monotherapy, which is taking just one medicine. And that is shown to reduce the risk of birth defects. We try to get her on the lowest effective dose of her seizure medicine. AED stands for anti-epileptic drug here. And so we don't want to trade a dose for seizures. We don't want you to have seizures when you're pregnant. I do check blood levels prior to conception. So before you get pregnant, I want to know what your blood levels are, particularly if you're seizure-free and well-controlled. And then I monitor those periodically throughout your pregnancy, and it's usually once a month. If your levels start to drop toward the end of your pregnancy, which happens fairly frequently, you may get blood draws a little bit more frequently. And then I would say if you're a woman that wants to become pregnant and you're on valproic acid or Depakote, you really need to talk to your doctor about if there are alternatives to that medication, because Depakote seems to be the one that has the highest risk of birth defects. And so really, I do almost anything to avoid using Depakote in women that are potentially pregnant. That being said, if Depakote is what controls your seizures, then we have a conversation about managing the risk. So I do have a few women who really, their only way to get control of their seizures is on Depakote. And then we have a conversation about the risk. So what happens if you have a seizure during pregnancy? So, everybody has different types of seizures. And so the biggest research has been done on the big seizures, what I would call the tonic-clonic seizures, or what a lot of people call the grand mal seizures. And so if you have just one of those big seizures, the baby is being put at risk for being small for gestational age, which can put them can give them developmental problems as they grow older. There can be a risk of preterm birth, and I have certainly, unfortunately, seen that in my women with epilepsy, that they have a seizure and they go into preterm labor. Seizures during pregnancy are also linked to low birth weight, and we don't know if there's a long-term impact on cognitive development of the baby. Now, focal seizures or focal unaware seizures, which we also known as complex partial seizures, there's just not a whole lot of research on those types of seizures. Theoretically, those risks would be lower than the tonic-clonic seizure because there's just not as much chance of injury, or they're just not as hard on your body. But we don't know that for sure. I do have some women with absence epilepsy who didn't outgrow it. And sometimes we do have to have some absence epilepsy during their pregnancies. And that seems to be okay. There doesn't seem to be much of a risk of having just pure absence seizures or the snaring seizures that people have sometimes. And so, managing your seizure medicines throughout pregnancy, we talked a little bit about this. We're going to get baseline medication levels. Ideally, these would be drawn before you get pregnant, but if you get pregnant, we're going to draw them at your first visit. And then monthly levels throughout pregnancy. And then I also usually do one after the baby comes, about 6 to 8 weeks after the baby, just to make sure that your medicine levels have returned to their baseline. Now, sometimes I will leave women on a slightly higher dose of their seizure medicine for the first 6 months, just because babies don't sleep. And a lot of women are very sensitive to sleep deprivation. So I just want to give them a little bit of an extra cushion just in case the baby doesn't sleep. What happens during labor and delivery? Most of the time it's normal. So you have the baby, whatever way is going to be best for you, for your OB. There is some data that C-sections and assisted deliveries, which are forceps or vacuum extraction, are more common in women with epilepsy. We don't really know why that is. I think some of it might be that OB doctors get a little bit nervous when they have a woman with epilepsy and they just want to get the baby out quickly. But the greatest risk of having a seizure during delivery is for the generalized tonic-clonic seizures. And that happens very rarely. The studies have shown that that happens in less than 1% of deliveries in women with epilepsy. So it's very rare, but it's certainly something that you want to make your doctor and your labor team aware of. Say, hey, you know, I have epilepsy. You also want to try to make sure that you take your medicines during the labor and delivery process. Just because if you're in labor, sometimes you might forget to take your medicine, but you want to try to make sure that you take your medicines, and that's going to reduce your risk of seizures. If you have a seizure during delivery, the OB team is there and they can assist you as needed. They might give you some medicine to help stop the seizure if it's needed. Breastfeeding, we do believe that the benefits of breastfeeding outweigh the risks of breastfeeding. And it's been shown that women with epilepsy who breastfeed, their babies get all of the benefits of breastfeeding, and it doesn't seem to have any risks. We do know that some of the medicines are present in breast milk, and that breast milk gets into the baby and the medicines get into the baby, but those levels are very, very low. And I say here the long-term effects are unknown, but they have actually done growth and development studies on babies born to women with epilepsy who breastfeed. That's a lot to say on a Saturday morning. And really, they haven't shown any difference in the babies who were breastfed or not, other than the babies who are breastfed do get those early developmental gains and benefits that the babies who were not breastfed don't get. And then I like to talk about a few practical tips. What are you going to do when your baby comes? And so I make sure that you have some systems so that you are going to remember to take your medicine, whether that's a pill box or an alarm on your phone, something, because that time, especially in the first few months when the baby's home, your schedule can get way off. And you need to remember to take your medicines, because I don't want you to have a seizure just because you forgot your medicines. So we know that missed medication doses and sleep deprivation can trigger seizures. And then I do talk about some common sense strategies and infant care and safety precautions, which I'll get into here in just a moment. So postpartum seizure triggers, and this actually I think is sort of a scary time for women with epilepsy, particularly if they have active seizures, because they're really worried about what's going to happen if I have a seizure. So one of the big seizure triggers is sleep deprivation. So we talk a lot about how to avoid sleep deprivation, one of which might be having the baby taken care of by somebody else at night. Physical and emotional stress can also trigger postpartum seizures. So we talk a little bit about that. And then once again, I want to make sure you take your medicines. I do tell people, you know, if you have active seizures, you might not want to carry the baby up and down the stairs, particularly if you have tonic-clonic seizures. I do encourage people to keep child supplies on each floor of their house, so you're not going up and down the stairs all the time. And then you might consider putting a sticker with emergency contact information on your baby's car seat, just in case you do have a seizure and you're out of it, and so somebody knows who to call. Postpartum depression does affect women with epilepsy, just as it affects women without epilepsy. It affects about a third of women with epilepsy, which is about the same as the general population. These are some of the symptoms of postpartum depression. So low energy, sleeping changes, being sad. And so I would encourage you that if you are feeling down or low or just not feeling good at all, you might want to talk to one of your doctors about whether or not you have postpartum depression. And sometimes postpartum depression can present a little bit differently. Instead of presenting with, the typical sad crying all the time, sometimes people can be very anxious and just have, more of this insomnia, restlessness. And so it really can affect women with epilepsy, and we can help you with it. So I would encourage everybody to talk to your doctor or talk to anybody who will listen if you feel like you're experiencing postpartum depression. And with that, I will conclude my talk and open it up if there are any questions.
Thank you so much, Dr. Hammond. That was I've got copious notes. This was actually really fascinating. I will see if Judy has any questions. Otherwise, I did have a quick question for you. I'm just going to give Judy a second. So if a woman is, considering becoming pregnant, how soon should they have those conversations with their epileptologist and their doctor in terms of like prenatal planning? I recognize sometimes it just happens, but
right.
If people are actively thinking, about starting a family, like when should they start having those conversations with their doctors?
So that's a very good question. And I talk with women who are of pregnancy age. So any woman that can become pregnancy at the very first visit. So when I see them, we have this conversation about, hey, what are you thinking about pregnancy? Is that something you want to do? Just so I'm thinking ahead that if we need to do additional testing or if we need to change their medicines, that we can do that at that point in time. But, sort of general advice would be as soon as you start thinking you might want to be pregnant, that's when you want to have that conversation. Definitely before you stop your birth control.
Yeah, right. That's fair. Okay, great. Thank you. And I think too, along those lines, it's so important to highlight, your whole healthcare team, right? You're talking, you're having these simultaneous conversations with your OB, your OBGYN, but also your epileptologist, and making sure that everyone's on the same page because they are part of your healthcare team and they care about you. And
absolutely.
I think that's a good distinction. I saw Judy came off of mute. Judy, how are you?